Hello, everyone who's already joined. This is Shobha here, and we'll just begin in 5 minutes. I think Professor Marx is a bit late because of some issues at his end. So we'll just give 5 minutes and then we'll begin. I think, yes. Meanwhile, if Sabita or somebody, if you want to make any announcements, please be free to do so.
Shobha,
Yes, yes,
afternoon.
yes.
Karina here. So, since I'm going to do some presentation, can I practice before I
Yes.
start?
Yeah, Savita, is that okay? But I think they're live
I
streaming
think
it.
we're gonna already start now. We can start. Professor Mark is here.
Okay, so we'll
Anytime you're ready. Yeah.
okay, so we can begin. We can begin.
Okay.
Okay. Uh, Namaste. Good morning, good afternoon, and good evening to all our participants who have joined from different parts of the world. A very warm welcome to each one of you. I'm Shobha Shukla from Citizen News Service, and it is indeed an honor and pleasure for me to moderate this Asia Pacific Regional Press Conference to end TB in the context of World TB Day 2022, which was recently observed on March 24 under the theme of Invest to End TB, Save Lives. This press conference is being organized by the International Union Against Tuberculosis and Lung Disease, or the Union as we call it, and the Asia Pacific Cities Alliance for Health and Development, or APCAT. With only 105 months left to deliver on the promise of ending TB globally by 2030, it is high time to take stock of where we stand in terms of TB care and control in this Asia Pacific region of ours. We have with us today a very eminent panel of experts to help us understand the efforts made and the challenges that our region is facing to achieve the end TB goal. Just a few quick housekeeping announcements before we begin. Participants, please keep yourself on mute while the speakers present. There will be a question and answer session after the presentation of each speaker and also towards the end. Please type in your questions and your comments in the chat box. Please also indicate the name of your media outlet. You can type in your questions even as the speakers present and not wait till the end. Without any further ado, I would like to welcome our first speaker for today, Professor Guy Marks, who is president of the International Union Against Tuberculosis and Lung Disease. Professor Marks is a noted respiratory medicine expert and lung health epidemiologist at the University of New South Wales, Australia. He will update us on where the Asia Pacific region stands in its efforts to end tuberculosis by 2030. He will also share the highlights of some latest scientific studies for TB care and control. Over to you, sir.
Thank you very much. And thank you, Shobna, for that kind introduction. And thank you to my colleagues for organizing this event to celebrate World TB Day, or maybe we should call it World TB Week, since we're going on a little bit longer. I'm going to try and organize to share my screen, if I can do that. Let me just work out how to get that right. Here we are. Okay, so we all want to end TB, and so my talk is about how we're going towards ending TB and what we might be able to do to get there. I hope you can see my screen. Is that somebody nod? Tara, yeah, good, thank you. Good, thank you very much. So what do I mean by ending TB? When we talk about ending polio or ending smallpox, we mean the complete eradication of these conditions, so you'll never see another case. That's not really what we need to achieve in order to end TB as a problem. And it's very unlikely that we'll be able to do that because, as you know, there are reservoirs of the organism in animals, and it will be very difficult to completely eradicate tuberculosis from the face of the earth. But we don't need to do that in order to achieve our overall goal, which is that it's not causing, that we have a world in which TB is not transmitted in an endemic way, where there is not ongoing by endemic, I mean ongoing continuous transmission of tuberculosis, and where people do not risk dying or being severely disabled due to TB. In fact, we have many countries in the world where this situation already exists, and I'm speaking to you from one now, in Australia. In Australia, there is no endemic transmission of tuberculosis, and the risk of dying due to tuberculosis or developing severe disability due to tuberculosis is extremely low. And many other countries around the world have, for the last 30 or 40 years, enjoyed that status. So we know that this can be achieved. This goal can be achieved. It's just that it has not been achieved in many countries around the world. Now, our focus really is on those high burden countries for tuberculosis, where there is still endemic transmission of tuberculosis, and where many people fear disability and death due to TB. And our focus is not necessarily to eradicate the disease, but simply to convert those places, those countries, to low burden countries like Australia and United States and Western Europe, where tuberculosis is not a major problem now. So that's, I think, what we're attempting to achieve. As everyone knows, there are very ambitious goals for TB elimination by 2025 or 2030 or 2035, depending on what you want to, which particular goals you want to subscribe to. But whichever goals you subscribe to, we are nowhere near achieving those goals. TB death rates are declining, but at a relatively slow rate. TB incidence rates are declining very slowly, about 2% per year, far, far lower than would be required to achieve anything like the elimination targets. So we are nowhere near, we're not just slightly falling short, we are nowhere near the targets that are required for TB elimination or for ending TB. I'm going to put to you my view that TB has only ever been ended in countries that have implemented widespread active case finding for cases. And in the early post-war years, in the 1940s, 50s, and 1960s, going on into the 1970s, many countries, including Australia, including the United States, including Western Europe, including the United Kingdom, and including Scandinavia, had community-wide active case finding programs that were associated with dramatic declines in the incidence and mortality rates due to tuberculosis. And this is an example from my own country, from Australia. For the whole century, what you can see here is that during the period of our national TB campaign, which started immediately after the Second World War and ended when there were virtually no more cases to find in 1974, essentially TB deaths and incidents were eliminated. It was this dramatic decline in incidence and deaths due to tuberculosis, due to active case finding. And by the mid-1970s, there were, as I say, not enough cases to find, and therefore the active case finding, community-wide active case finding was stopped. And this was replicated all around the world. And in 1974, WHO issued a statement saying that active case finding was no longer an appropriate intervention. Well, in retrospect, that was an extraordinary decision for them to take, because it was taken on the basis of the fact that there were no more cases to find in Europe, in North America, and in Australia. But there were plenty of cases still to find in the rest of the world. The disease had not been eliminated in most of the rest of the world. And yet they made this decision, presumably on the basis that there were no more cases to find in Europe. I think an extraordinarily short-sighted decision. Since that time, there has been the idea of active case finding for tuberculosis has fallen out of favor. And there was a view, I think, commonly held that active case finding could not be done in high burden countries and would not work. So we did a study. It has never actually been tested in a randomized controlled trial. You know, randomized controlled trials are the technology we use to assess the effectiveness of all sorts of interventions, drug and non-drug interventions. So we did a randomized controlled trial. Oops, I'm going to have to go through. We did a trial in Kamau, in the southernmost province of Vietnam, a population of about 1 million people, quite a high burden of tuberculosis. We did a cluster randomized controlled trial in which we randomized to an intervention in which people were screened once a year, each year, for active tuberculosis, and a control group which did not get screened. And at the end of the during the randomized control trial, we engaged with the community. We went from house to house. We did a household survey to inform people about the study and get their consent to participate. We collected from everybody who was able to produce sputum, a specimen of sputum, and we tested it using the expert platform for molecular testing of sputum. And this is a diagram showing how we explain to people how to produce a sputum specimen. And this is a photograph of some of our staff shown here on the left, meeting a patient who was, these were fishing villages mainly in the Mekong Delta, and this is collecting data. So these are the results, basically, what you see here. And what you see is that year on year, from the beginning, the first year of the study to the fourth year of the study, there was a 72% decrease in the prevalence of tuberculosis. Now, remember, I said to you before that the reduction in incidence of tuberculosis that's being observed around the world with the current strategy is 2% per year, which would mean over 4 years, it could be 8%. We achieved here a 72% decrease in the prevalence of tuberculosis. And when we compared it to the control group, it was 44% lower. So between 72% and 44% increase in case finding, if you like, a reduction in prevalence of tuberculosis with this intervention. This is the sort of change that is needed if we're going to achieve TB elimination. 2% per year will never get us to TB elimination, or will take forever. 44% over 4 years will get us there over a period of time. This intervention was only done in adults. We did active case finding for TB in people aged 15 and over. We did nothing in the children. But we did test the children for whether or not they had TB infection. And what we found is that the children who lived in the villages, the clusters where we'd done the active case finding, had 50% lower prevalence of TB infection than the children who lived in the control clusters. And what this means is that finding active case finding, or finding cases of TB in the whole population, if you screen the whole population of adults, you will prevent new infections. You'll prevent infection with TB, primary prevention of infection, and infection is the thing that leads to TB disease. So this was very important evidence that not only can we reduce the prevalence of TB disease, but we can reduce the number of infections. And these infections prevented is a big part of the way to TB elimination. So I'll just conclude by saying I think we can end TB in the near future using a model something like this. We know that it's been done in the past in many countries around the world. It was done in all of the Western Europe, in North America and in Australia. And it's also been done in Japan and largely done in Korea. We know we can achieve this, but we need to make a commitment to a pathway to actually implement it. There are some research questions still to answer about how best to implement it. And we need to engage with stakeholders, with politicians, with communities, with funders and donors, with all of the key stakeholders in this process. If we do all these things and we stay the course, we will in fact end TB. And that's my commitment and the commitment that the union wants to make for our region and for the globe. So I'll finish there. Thank you very much.
Thank you, Professor Mark, for stressing the importance of active case finding as the first major step to enable no endemic transmission of TB and no disability and death due to TB. And also thank you for your optimism that has energized me already, that all is not lost. Yes, we are far behind, but yes, we have to move ahead. We now open for question and answers. Participants, please type in your questions in the chat box. We already have a few questions. There is a question from Nahid Khalid, and Nahid says that we read in the news that TB deaths are rising. But Professor Marks, you said that TB deaths declining, but not fast enough. So can you please clarify this for me? This is
Nahid. Yeah, sure. I mean, TB deaths were declining prior to COVID. There was a small increase in 2020, and that is attributed probably to the interruption of the care of patients with TB due to the COVID pandemic, because many patients with TB couldn't get access to care. So yes, they did rise globally in 2020 and probably will rise again in 2021. But it is true that the current strategy prior to the COVID pandemic was leading to a slow decline, both in incidence and in death rates. And that's because the treatment is effective and more of it is available, largely due to the Global Fund programs. So patients who are diagnosed and treated are now getting treatment and therefore prevented from dying. But we're making very little progress towards TB elimination. And really the best way to prevent people from dying due to TB is to prevent them from getting TB in the first place. The next best way is, if they do get TB, to give them effective treatment. But the first best way is to prevent them from getting TB in the first place. And that's what I'm talking about. We need to, and that is about case finding, preventing transmission. And that's why that slide that I showed you, which was just about children, but it's really about all infection. It's saying that if we find and treat all of the cases in the community, then other people won't get infected. And by stopping people from getting infected, we'll stop them from getting TB, and therefore we'll stop them from dying.
Thank you. There's a question from Ten Mong Kyo, who heads the Health Digest Journal in Yangon, Myanmar. He wants to know which Asia Pacific countries are better off. Of course, none are on the track to end TB by 2030, but are there some countries which are better off than the rest?
I think it's hard to know for certain. Clearly, some of the more wealthy countries that have invested heavily in TB control, like obviously Japan, South Korea, as I said before, and Taiwan, they have made really substantial progress towards TB elimination. There's no question that those countries have made really substantial progress. Thailand and Malaysia have made some progress, and they've also invested. And China has made some progress as well, but China still has a very long way to go, and so do most of the other countries in our region. Have a very, very long way to go towards TB elimination. I mean, the country that you're talking about, Myanmar, clearly have a lot of issues at the moment that are being dealt with and that are interrupting the capacity to deliver care for patients with TB. But ultimately, the solution in Myanmar is the same as the solution that I've been describing elsewhere. It's about finding all the cases and treating them.
We have a question from Kalpana Acharya, editor-in-chief of Health TV Online, Nepal. Kalpana says in Nepal, around 60% TB cases go undiagnosed. What are your suggestions to accelerate efforts to meet the global targets? And how can the media help in this?
Very good question. Well, my suggestion, the reason, and I didn't go into this, the reason that cases go undiagnosed is really twofold. There are two potential reasons why cases go undiagnosed. One is that people who have symptoms of TB, who have cough basically, or weight loss, or coughing up blood, who have symptoms that would normally lead them to seek medical care, are not able to get effective medical care for because of health system problems. Either they can't get to a healthcare provider because they're too far away, or the healthcare provider that they get to does not have the tools or the capacity to make a diagnosis of TB, or they do make a diagnosis of TB, but they can't get the patient onto treatment for TB. So all of these sort of health system issues are one category of ways in which TB can be missed. But the other way, which we've not really acknowledged or recognized until fairly recently, is that in fact there are quite a lot of patients who have very few symptoms of TB, if any. And when we do these prevalence surveys in countries where we do screen everybody, like the study that I was just describing to you, what you find is a lot of people who actually have infectious pulmonary tuberculosis, but who are not got any significant symptoms, and therefore, even with a perfect healthcare system, are not going to be diagnosed, because people who don't have symptoms don't seek medical care and cannot be diagnosed. So that is why I believe that active case finding, that is community-wide screening of people for TB with a test that does not rely on symptoms to make a diagnosis, either chest X-ray or sputum examination, is required to find all of the cases. Because unless you find all of the cases, or nearly all of the cases, you will get continued ongoing transmission. You will get what I call endemic transmission. So what can the media do? I think the media do have a very important role. The media, what concerns me is that people in highly endemic countries are not demanding this. The people in countries where there's a lot of TB transmission, where a lot of people are being infected with TB, should be asking, how did I get infected? Why did I get TB? Why did my government allow me to come into contact with somebody with untreated tuberculosis and get infected? Why aren't they finding and treating all of the patients with TB to protect me from getting infected? That message needs to get out there. People need to be demanding that governments invest in active case finding to reduce their risk of being infected with tuberculosis. It's not just about finding people for the benefit of the people who are found. It's about finding people for the benefit of the rest of the community so that they don't get infected. And it's a message that we all learned with COVID. You know, with COVID, we all learned that if other people in your community don't wear a mask and stay isolated when they get the disease or take vaccination, then that's a risk not just for them, but for me, for everybody else. And it's the same with tuberculosis. It's an infectious disease, and people who have the disease, if they're not found and treated, they will infect other people. So that's, I think, the message that we need to get out.
Thank you. We have a question from Chhatra Karki, who is a science and health journalist based in Kathmandu and is the founding president of Nepal Forum of Science Journalists. He wants to know, Professor, what are some new researches or new medicines to fight against multi-drug resistant tuberculosis as it has become a big burden for countries like Nepal and other least developed countries also.
Okay, so that's a sort of separate topic, but it is an important one. You're right that multi-drug resistant tuberculosis has been a major problem, and treatment for multi-drug resistant tuberculosis has been difficult from several respects. One is that it is not as effective as treatment for drug susceptible tuberculosis. Second, it is very expensive and therefore not accessible to many patients. And thirdly, it is often more toxic. It causes side effects. It's unpleasant. It used to require injections, which had side effects. So the toxicity and side effects of the treatment were a problem. So the lack of access to the treatment due to cost, the toxicity of the treatment, and the less effectiveness of the treatment were all major problems with treatment of multi-drug resistant tuberculosis. There have been really giant strides made over the last decade, I guess, in treatment of multi-drug resistant tuberculosis, and WHO is regularly updating its guidelines based on new evidence. And there will be further update of the guidelines later this year. And I'm pleased to be able to say that, that the treatment is becoming less toxic, much more acceptable to patients, much more effective, and much more available than it was before. What's important for multi-drug resistant tuberculosis is that patients who have it are diagnosed early, and we now have, that's the other thing, is that we did not have good tests available previously to identify patients who have multi-drug resistant tuberculosis. We now have good tests that can be performed immediately when a person is diagnosed with TB, and they should be performed immediately when a person is diagnosed with TB. And so that patients who do have multi-drug resistant tuberculosis are started on the appropriate treatment straight away, not as we used to do, waiting for them, giving them standard treatment and waiting for them to fail with that standard treatment, during which time they're at risk of spreading the multi-drug resistant tuberculosis to a whole lot of other people. So multi-drug resistant tuberculosis patients had very delayed treatment and were often got very sick themselves, and also spread the disease to a lot of other people. So all of those things have changed quite dramatically. I said 10 years, but really it's even a shorter period than that. It's really probably only the last 5 years that these dramatic changes have come into place, and further changes will be coming about soon. So I think we can be optimistic that we're going to get on top of multi-drug resistant tuberculosis in the near future.
Thank you very much, Professor. I now invite and welcome Dr. Erlina Burhan, a noted TB expert who has been leading the fight against TB in Indonesia for the last 30 years or so. She is also the head of TB Assembly and chairperson of the Indonesian Lung Doctors Association and is on the board of directors of the union. Arlena, you have been deeply involved with TB care and control for long. Can you please give us an overview of the TB prevention, diagnostics, and treatment services in your country? What are the gaps and how to address them?
Okay, thank you, Soba. Good afternoon, everyone from Jakarta. I would like to answer that question by doing my presentation. I know that the time is only for 10 minutes, so I will adjust my time. So this is my topic, the TB prevention, diagnostic, treatment, and care, and what are the gaps and how to address it. First, I would like to share with you the Indonesian situation. Currently, TB incidence in Indonesia is really high. We rank third in the world, and our estimated TB cases are 824,000 a year, and this means 301 per 100,000 population. And the highest burden is estimated among the age group young and productive, and also men was higher than women, and mostly are in urban area and among seniors over 65 years old. What about the death? So there is estimated 93,000 people died from TB HIV negative in Indonesia in 2020, meaning that 11 people died per hour. So if this event occur for 1 hour, there is 11 people already died in Indonesia. Regarding the notification, there is an increasing notifications in 2017. We can achieve like 5,680,000 in 2019, but the figure decreased drastically in 2020 to only 390,000 something due to COVID-19 pandemic. And complication arise from low case notification and also low treatment success rate. In 2018, we can notify around 570,000 out of 845 estimated patients, but only 67% treatment coverage, meaning 1/3 of the patients were either diagnosed but not reported, or not diagnosed at all, known as missing cases, meaning that this number remain as a patient that infectious and transmitted the disease to other. And also, as happened in other country, COVID-19 pandemic lowered this achievement. During 2020, and the treatment coverage was only 43% and 47% in 2021, even lower than 2018 and 2019. And the treatment success rate was also below 90% WHO target. We only reached 83% and 84%. So around 15% patients remain unsuccess, meaning they probably develop TB drug resistant. So this is the treatment coverage. We can see here that it is declining a bit, increasing just a bit in 2021, and we do hope that it is will be increasing again in 2022, since the situation is with pandemic is getting better. Now, problem in prevention. Estimated caseload of latent tuberculosis is around 2,795,000 people are in contact with active tuberculosis cases. So meaning that this number need to be tracing and also diagnose whether they are having TB or even only having latent TB. But even with latent TB, our coverage of tuberculosis preventive treatment in children, which is the program of our national TB program now, doing TPT in children under 5 years and also among HIV positive patients. But for the treatment prophylaxis, we achieve very, very low number. in 2019, only 12% of people living with HIV that being covered, and only 5% of child household contact aged less than 5 years who were eligible for TB preventive treatment received the treatment. It represents a huge missed opportunity to protect them from TB and risk of death. So that are among children under 5 and among adult with HIV. And actually TPT also need to be given to adult patient, but this is not in our national program yet. However, individual prescription already took place in the hand of pulmonologist, my colleague, and also my colleague from general physician. There is a problem in diagnostic as well, that the access to gene expert testing services remain the key limitation. The limitation of the machine and all the mapping of those who need to have this machine. And also our problem is not working for diagnosis is still problematic, since the number of gene expert not enough. So we have to do this referral system for diagnosis, and still this is a problem in implementation. Problem in treatment, there are people being diagnosed but not start the treatment, and if the treatment is start, is used sometimes is delay for many reasons, and there are missing cases, as I mentioned earlier, that they are being diagnosed but not initiate the treatment. And also those who are start the treatment, at the end they are not finished, so this is a group of lost to follow up for a variety of reasons. What are the solutions? So the COVID-19 pandemic is really hit the country, but I somehow thank to COVID, because there are a silver lining from COVID-19 pandemic that actually can be implemented in TB program as well. The 3T approach, tracing, testing, and treatment, is really work for COVID, and I feel this kind of approach, the 3T, testing, tracing, and treatment, if applied and implemented in TB program, so it will give a huge benefit for the program as well. And also the preventive treatment should be put in attention also, because our achievement is very, very low, only 12% among HIV and 5% among children under 5 years old. And I think we need to adopt real-time COVID-19 notification. The platform of this notification for COVID is works really, really well, and I'm also very sure that this can be done also for TB. So let's invent the technology for TB as what we do for COVID. So as for tracing, Dr. Mark mentioned earlier that active case finding are really good strategy, and I think I agree with that, active case finding is necessary strategy for finding the 30% of cases that are mixing each year worldwide, and that's also I think apply in Indonesia. And for this active case finding, we need to have community engagement, because this activity cannot be done only by Ministry of Health staff, but we need the participation of local government, because those who know the situation and those who are having access to the people, to the household contact. And this active case finding policy advising institution of in healthcare facility with systematic screening using chest X-ray, whether this is a conventional chest X-ray or artificial intelligent one, but this should be included in active case finding, and together with molecular diagnostic testing. As I mentioned also earlier, that community engagement with active leadership of local government is very, very critical. This is one aspect that are not being uh, are not being implied in my country yet. And tracing using digital technology such as Peduli Lindungi, that is in Bahasa, Sijejak or Silacak. This is a digital platform in COVID-19 system, can be used also for TB. And for the testing, I think NTB should expand the facility and also increasing the utilization. And please update and socialize national TB guideline because there are so many updated right now. For instance, for drug-resistant TB, right now there are all oral regimen which and also short regimen which is very friendly for the patient, and also especially for the pre-XDR and XDR patient, the introducing the BPAL regimen to the national program is one of the strategy that will give a benefit for drug TB resistant in the TB program in Indonesia. Regarding the preventive treatment, strengthen the commitment of TPT, TB preventive therapy. Make the uptake of TB preventive treatment as one of the key indicator, along with other TB indicator, and also develop the capacity of healthcare worker to offer TB preventive treatment, including counseling and proper management. In the reality, a lot of healthcare workers still are not confident enough to diagnose a latent TB and also not confident enough to give treatment. So we have to do some training and also education, not only for the patient but also for the healthcare worker in the ground. So the NTP, I recommend that our NTP that need to expand preventive treatment to all household contact people with bacteriologically confirmed TB and as well as other risk group, taking into account the local context. The theme of World TB Day 2020 is invest to end TB, save life. I think for Indonesia, we need to focus on the last three: erasing stigma, innovation and research, and the most important thing is collaboration and multi-sectoral action. In COVID, from president, all the minister in the country, the business people, all the community leader, and even the people in general, all collaborating to prevent and treat COVID. I think if we can do the same for TB, we will achieve all the milestone and the target in 2030, TB elimination. Thank you very much. Last one, I would like to say that World TB Day is should not only in March 24. I believe that TB Day is every day. Thank you very much.
Thank you very much, Erlina, for giving such a clear overview of the situation in Indonesia, and also for talking about adopting COVID-19 measures in the TB field also. Any questions for Erlina? We do have a few questions for you. There is a question from Rita Vidyadana, a very senior journalist from Indonesia. She was formerly with Jakarta Post and now country director for Consortium for Press Freedom. Rita wants to know, how has COVID-19 pandemic affected TB services in Indonesia, and what will be the repercussions in future also, given that all financial and other resources have been reallocated for COVID-19 response?
Yeah, very, very sad to say that during pandemic, a lot of resources are switching to handle COVID-19. Not only budgeting, but also the human resources. A lot of TB healthcare worker then shifting to work for COVID. And also a lot of TB clinic or patient are being closed because they all doing COVID. So meaning that this diagnosis or case finding is reducing, and also many of TB patient not coming to the clinic for to continue the drug. So I'm afraid, very, very afraid that this will increase the number of MDR. So, and even with our diagnostic tool, our gene expert was also relocated for diagnose COVID. So everything for COVID. This is a very sad story, but it's happened. So I mean, since now the COVID-19 is declining, let's go back again and give more of full attention again to TB. Bring back all the healthcare worker working for TB. Relocate our gene experts again to diagnose TB, and also open more and more clinic for TB.
Thank you. We have a question from Bobby Ramakant from CNS. And Bobby wants to know that is COVID or long COVID also a risk factor for progressing from latent TB to active TB disease? And what can we do as TB preventive therapy coverage is so very low?
Yeah, I think we should be aware that those who are catching COVID are those with problem of low immune system. So that is also apply for COVID, for TB. So when some people having COVID, meaning there is a damage in the respiratory system. So those who are already having latent TB, I think can develop to have their dormant bacilli to be reactivated and become active TB. And also yet the additional factor is the smoking. Around 60% of male adult in Indonesia, they are smokers. So this is also will reduce the capability of ciliary clearance, respiratory clearance for any bacterial that inhale to the system. So I mean, there are a factor of reducing immune system, even worsening by having COVID, and also the situation that 60% of male Indonesian are smokers. And as I mentioned earlier in my presentation, the higher burden is in the male for COVID and also for TB.
Okay, thank you. We have a question from Denny that I read in the World TB report that tobacco use, this is what you mentioned just now also, Arlena, tobacco use, undernourishment, alcohol use, and diabetes are major risk factor of TB. Is integrating the TB program with these programs feasible in Indonesia? And how far do you think such initiatives could help in the TB elimination agenda?
It very visible, very visible, but we have to put the commitment in every sector. With diabetic people, with the people who fighting for tobacco smoking and other situation. So commitment need to be increased there. And I would like to say also that TB is not only the work of medical personnel, but TB is everyone business, including those who work for tobacco control.
Okay. One question, another question from Aditya, that how is the situation of people with MDR TB in Indonesia, especially during COVID-19? Again, and I think that applies to other countries as well, not only Indonesia, I think.
So for MDR is even, for me, it's frightening. Yeah. A lot of loss of follow-up being found, and also those who are already as a suspect or meeting the criteria of DRTB, they are afraid to come to the hospital or the clinic because they are afraid of catching COVID. And I think that's why the mortality of TB is also increasing, because they do not get the proper treatment. They're afraid to come, and also some of outpatient clinic also reduce their service, not every day but every intermittent day. Yeah, so there is also a problem. Yeah, I think in any country that pandemic do the disruption of the achievement of TB services and TB program. But we cannot just waiting for that, but we have to improve. Learn from COVID. Thank you, COVID. There are a lot of best
Yes.
practice that can be applied for TB, especially 3T, tracing, testing, and treatment, and isolation. That is really applied for TB, and we need to do this with commitment and also good implementation on the ground, not only on paper.
Thank you very much. And thank you for again stressing that we have to see the silver lining in the dark clouds of COVID and at least use that silver lining in the field of tuberculosis care and control. Thank you very much, Dr. Burhan.
Thank
And
you, Shobha.
we now move on to our next speaker, Professor Abdul Razak Mutallif, who is Senior Consultant Chest Physician and Head of Medicine at Mahasa University, Malaysia. Professor Mutallif will tell us about the TB situation in Malaysia and how to address the very pertinent problems of latent TB, latent tuberculosis, as well as drug-resistant tuberculosis. Welcome, Professor, and over to you.
Thank you, Shobha, for your nice words. And I'd like to thank Dr. Tara Singh for inviting me to talk on this press conference. Malaysia is quite fortunate to be having not so many cases of TB. Last year, we got about 21,700 cases of TB. That is a bit lower than the year before. The year before was 23,000. And because again, like what Dr. Alina mentions now, the COVID has already brought the TB cases down in Malaysia by about 10%. So our cases are a bit low, not to be happy, but we're not catching the cases like before. That's the other thing. Again, if you look at the number of cases that WHO predicted for Malaysia, we are supposed to get about 101 cases per 100,000, and we only have about 68 per 100,000 right now. So if the prediction of WHO is correct, we are actually missing some TB cases in Malaysia. So the year before, we predicted we lost about 6,000 missing cases in Malaysia for TB. So in that sense, although the TB case is low in Malaysia, we are not catching all the cases that we are supposed to catch in Malaysia because of few reasons. One is awareness of TB is not there. And TB, again, is not the main thing we worry. The people in Malaysia still believe TB is no more in the world. They say believe TB is already gone and gone. No? So the TB actually is still in Malaysia, but so people do not actually see about TB in Malaysia very well. Again, the detection rate for TB by the doctors, again, is a bit low because many centers in the private don't have clinics with X-ray. If you look at the number of clinics in Malaysia, it's very interesting. In Malaysia, we have about, let me just give the figure to you. In Malaysia, we got about 1,061 clinics in the health side, the government clinics. In the private, there are about 7,000 clinics in Malaysia for private practice. So this is really a lot. So when the patients go for a cough in the private clinic, and then they say they're having cough and cough and cough, so they maybe miss TB case because X-ray is not done, and the sputum is not done. So in that sense, we are missing cases of TB in Malaysia. That's the reason why we're not getting a target proposed by WHO. But the good thing is that the case is not so high compared to the neighboring countries in Malaysia. Again, the other big issue in Malaysia, we actually have TB is, I'm sorry to say this, we have a lot of foreign workers in Malaysia for development and for construction and for meats and for many other works. So the good thing is that we have a thing called FORMEMA. FORMEMA stands for Foreign Workers Examination. So we examine every worker from outside Malaysia to check for TB, HIV, VDR, syphilis, hepatitis, and also the other disease. So in that sense, we screen them for TB before they come to work in Malaysia. So this is a very good thing because we find that the workers of coming to Malaysia to work for in our countries, it's only about 10 to 12%. Not very high compared to other countries. So foreign workers, immigrants, it's only about 10 to 12% in Malaysia for TB. The other issue we have in Malaysia for TB is that we got the immigrants and we got the refugees, not the refugees. We got some refugees coming from neighboring countries. So unlike other countries where the refugees are kept in one camp and they are controlled in one camp, in Malaysia, the sad thing is that the refugees are free to move. So they are moving everywhere in Malaysia, the refugees. So we can actually contain them in a place and check them for TB. So although there's a UNHCR in Malaysia for all these refugees, Only some go there because they come in the proper channel. So we have a lot of refugees come illegally through the sea and through the land. So they're actually hiding somewhere in the country. We cannot actually catch them for TB. So this is another big issue we actually have in Malaysia, where although it's not a big number, but it does definitely make a number of TB cases that not detected in this group, which is really a special group for TB because they come illegally and they also not recognized to be in Malaysia for this TB again. So the good thing about again for TB in Malaysia is our case is not so high. We got a very good healthcare system in Malaysia to control TB very nicely. And our treatment success rate for Malaysia for TB control is almost 90%. So in that sense, it's very, very good. So that's one thing good about TB in Malaysia. What about LTBI? Latent TB treatment in Malaysia actually we are actually doing a good comeback right now. WHO already came out with the LTBI guideline many years ago. And when I was the Ministry of Health about 5 years ago, I left about 5 years ago, I was telling them that we should make LTBI as the treatment guideline in Malaysia in the policy. And I'm very happy to say that it's already in the government policy for LTBI treatment. We started in 2019, about 3 years ago. And we are going very fast and very good to detect more patients in the LTBI group, and we treat them effectively. We're using mental tests for LTBI before. And now we got very big centers in every state where they can do the regular testing for the LTBI. So in that sense, we are actually moving forward to catch more patients in the LTBI group. And hopefully, like what Bob Guymark said just now, that treating the active TB cases, finding them is one arm for you to bring the TB down. And the other arm where about 1/4 of the people in the world got latent TB, you got to actually address them properly. So we're actually catching all those people with latent TB in Malaysia in active form. We're going to see them in the old folks home, in the HIV positive patients, in the prisoners, in the refugees, in the immigrants, and also people who got diabetes and young people who are smokers. And the worst group I think you all should know is the healthcare workers. The healthcare workers in Malaysia got a very high rate of LTBI infection because we don't have a specific ward for TB in many hospitals in Malaysia. We only got some centers where they got special ward just for TB cases. So many wards in Malaysia, we actually mix the cases up with TB and also non-TB wards. So the staff there are actually exposed to TB patients before they actually diagnosed for TB. So LTBI case in the healthcare workers is a bit alarming, but we're catching them early. And now with the IGRA testing, we are doing a very good job to catch more patients actually with all these infections earlier. And then the treatment rate right now is getting much better right now. So last time the rate was a bit low for the HIV positive patient. Before this, we only treat the HIV positive patient and also those children less than 5 years old. Right now, with the new guideline for LTBI treatment, they're going really forward, educating the public, educating the doctors in the private, and also educating the government doctors who see patients with TB here and LTBI to catch them early. And with the patient, the contact tracing and LTBI in Malaysia, we got almost 2% of patients positive for LTBI with TB disease. So that is a very good number for this LTBI treatment in Malaysia right now. So we are moving forward. We are moving forward with lots of things in Malaysia to catch TB. And the only lacking part I told you just now is we are still missing some cases in the country where we can do much more. And we are doing a lot of collaboration work with the communities, with the CSOs, with the NGOs, and to hopefully to sort of to get more people to work together to fight the TB properly. And like Alina mentions now, TB control program is not just a Ministry of Health problem. The TB control program is a problem for the whole country. And everyone should take a part in make sure that TB is controlled by every person in the country, and it's not just one person alone. So that's one thing actually fighting for in Malaysia. MDR-TB, my last thing about MDR-TB is very interesting. Again, MDR-TB, we are very fortunate in Malaysia. Every TB patient in Malaysia, if we diagnose, we send every patient's sputum for culture and sensitivity. We've been doing this for more than 10 years right now. So every patient, if the AAB come back as positive in the sputum, we will send them routinely for the culture by 2 methods, the solid media and liquid media. So by doing this, we actually catch not a patient with MDR-TB or even resistant to isoniazid or monotherapy resistant, whatever it is. So we're catching them early for all these resistant cases for TB in Malaysia, because we do culture for everybody for the past 10 years. The moment you're diagnosed TB, we send them a culture. And right now, we got good thing like the LPA and also gene expert available very easily in Malaysia. We are very fortunate that, like I say again, Malaysia is a small country. We got very good lab services in the country, and we're catching lots of MDR-TB cases in the country earlier. And our success rate for MDR-TB in Malaysia is, again, I must say, fortunately, about 70% success rate for MDR-TB. XDR-TB case in Malaysia is just 1 or 2 cases so far. Touch wood, you know. We are fortunate because, like I say, we got a very good healthcare system in Malaysia for TB control program, and our success rate for TB control program and TB treatment is really good. And because of this thing, the MDR-TB rate is much lower compared to other countries. The other bad thing about MDR-TB, again, like I mentioned just now, is that it's brought in by the foreigners. Like I said, some are coming illegally to work in Malaysia. And we also got refugees coming to Malaysia illegally. So these are the people we actually miss the MDR-TB cases. Because they come illegally, they do not want to come and see a doctor, they're not feeling very well. So then again, they will transmit the MDR-TB to the people where they're staying together. That's another big issue we actually face. So right now in Malaysia, our population of 32 million and the case 21,000 TB, we only got about 222 cases of MDR-TB in Malaysia. That is really fantastic for us. We are very fortunate. From 0.3% of MDR-TB cases about 15, 20 years ago, now we're touching maybe just about 1% of cases with MDR-TB in Malaysia. So my conclusion will be the TB control program in Malaysia is doing very well. We got a very well organized healthcare system in Malaysia to tackle all these issues. We are still missing some cases we can actually go forward for that. And LTBI is really moving forward very fast for the past 3 years. We are trying to do a lot of IgRA testing for almost everybody. We've been trying to do only mental tests for some people, not all the people. And MDR-TB cases, again, we are fortunate. It's not a big issue in Malaysia at the moment. We are tackling them in a proper way. Thank you very much.
Thank you very much, Professor. And thank you for focusing on latent TB, because that is the pool and that is the group we really have to deal with and tackle, so that there are no more active cases, because every case of active TB comes from that pool of latent TB. Thank you very much. We have a question for you from Shio Chin Tan, who is Deputy Editor Health at the Star Media Group in Kuala Lumpur. Shio wants to know that what needs to be done to address the misinformation in general public around TB in Malaysia. For example, she says many Malaysians think that there is no more TB and it's a disease of the past. And some believe that BCG vaccine protects against tuberculosis. So what should be done to...
And that's the point I mentioned just now. Yes. In Malaysia, we always feel that TB is no more in the world. That's because we do not talk about it. So the publicity and the media, I think, plays an important role here. Like what Alina mentioned just now, TB Day should be every day, not only March 24th. So when people do not talk about it, people just forget about it. So wherever there's a chance to talk about TB, I think it's very good that a newspaper, Star is a very good newspaper in Malaysia. It is, I think the coverage for Malaysia, for people reading Star is really very good. And now everything is online. So it is very good to highlight TB regularly in papers and also any other form of mass media, that TB is still around. It's still around. And Malaysian government is very good in the sense that we got a TB guideline about 10 years ago. We may actually are supposed to launch a new one just on the World TB Day. It's coming soon. We only say that anyone who cough more than 2 weeks, think of TB. That's in our guideline. So this should be mentioned to everybody in the country. If you cough more than 2 weeks, please think of TB. Right now, COVID is a main thing. COVID is a hero right now. Everyone thinks of COVID. In a way, like what Alina is saying, is very interesting. Similarly, because of COVID, we are catching a bit more new cases of TB. That's a good thing. When somebody cough and cough and cough, we think of COVID, yes, but when you check for TB come back as positive. So we must say thanks to COVID, because it does catch a bit of new excitement of TB in some places where people think of TB. It's very interesting. So once again, the media plays an important role. Remind people on and on again and again that TB is still there. It hasn't gone for the past 5,000 years.
Thank you very much, Professor Muttalib. And now I invite the guiding force behind today's press conference, Dr. Tara Singh Bam. Dr. Baum is the Director of Asia Pacific Office of the International Union Against Tuberculosis and Lung Disease, Singapore. He is a world-renowned tobacco control leader and strongly believes that tobacco control is an essential intervention to help end tuberculosis. Welcome, Dr. Baum, and can you please tell us what actions need to be taken by countries in our region to curb this totally avoidable risk factor for contracting TB? Over to you, sir.
Thank you, Shobha, for a nice introduction. Let me fix my screen. Can you see my screen?
Yes, we can see your screen.
Thank you. So, the earlier speaker, Professor Guy, Dr. Elena, and Dr. Rajab, they all highlighted the need of the community participations, local actions, translating the government's commitments into action at the local level and the communities. And there are several interventions that have been carried out and also will be carried out in the future to really eliminate the TB and control the tuberculosis, let's say. So in my the quick presentation, I would like to highlight something about the factors that also attributable to the TB. See, one of them is the tobacco. So I have put my the title here. You can see the investment in tobacco control would contribute to end tuberculosis. So just let me highlight some facts. What is the problems of the TB and tobacco, and how we are going to really address this issue to solve together. So if you look at the burden of the TB and tobacco smoking, the many evidence is suggests that it's a deadly combinations. So at the global level, as earlier other speakers highlighted, there were actually the 10 million people fell ill with TB in 2020 at the global levels, and 1.5 million people died from TB in 2020. For tobacco control, it's about 1.3 billion tobacco users are there worldwide in 2021, and about 8 million people died from tobacco, the related disease each year globally. So if you look at all these figures, it translates like about 1/4 of world's populations has a TB infection, and 1 in 5 cases of TB disease around the world are attributable to tobacco smoking. So this is something real, the issue that we need to address together. When I say we, both tobacco control community and TB control community should work together. So, regarding the science, the science that we have up to now, it says there is several, the connection of the tobacco smoking with the TB and TB, the treatment outcomes. So people who smoke tobacco and are exposed to tobacco, the smoke have a greater risk of developing TB and are less likely to be cured from the TB diseases. So that is the evidence as established by the many scientists around the world, and it has been acknowledged by the World Health Organizations and the Union in 2007 and published the guides. And this monograph really presents a comprehensive the approach to address the TB and tobacco problems. People, it also suggests people who smoke tobacco have a greater risk of dying from TB disease. And further, it suggests people who smoke tobacco have an increased likelihood of relapse after TB treatment and greater clinical severity and delay in TB diagnosis and treatments. This slide presents the key drivers of the TB epidemics at the global levels. As Dr. Erlina earlier mentioned, the smoking is also one of the key risk factors for the TB. Similarly, there are many new TB cases are attributable to 5 key risk factors. They are the undernutrition, HIV infections, alcohol use, smoking, and diabetes. People who are infected with HIV are 18 times more likely to develop TB disease. Actually, it's more the prevalent in Africa. And people who smoke are 1.6 times actually more at risk globally, more risk. And at the global level, in 2020, the WHO reported that there were about 0.73 million new TB cases that were attributable to smoking. So I would like to highlight here that Indonesia is one of the high burden countries both for TB and tobacco, and similarly there are some other countries as well in the regions, including India, Philippines, Myanmar, and there are many other countries, China as well. So as per the WHO Global TB report, among others, the smoking remains as a main risk factor for TB in India, Philippines, as I mentioned earlier, Myanmar, even Thailand, and many countries around the world. In Indonesia, undernutrition, smoking, and diabetes are the strongest driver of TB epidemics. In 2020, there was WHO joint external monitoring missions, and it highlighted that the TB, about 300,000 of TB cases annually can be attributed to smoking in Indonesia. So this is a really huge figure. If you translate in numbers, it's over 35% of TB cases actually are attributable to tobacco smoking in Indonesia. And Indonesia is a country where smoking prevalence is quite high, and about 65 the million the smokers lives in Indonesia. So therefore we can see that there is the very significant correlations between smoking and TB in Indonesia and other countries as well, for example in India. In terms of the prevalence of smoking in TB populations, there was some study published and found that the TB prevalence of tobacco smoking was found substantially high in people with tuberculosis compared to in general populations. In India, the prevalence of smoking was about 90% in male TB the patients, that you can see the red bar, and while it was only 42% in general population. In Indonesia, actually the almost all male TB patients they used to smoke, but again as I mentioned earlier, the smoking prevalence in general population, even in the male population in Indonesia, also quite high at 65%. So similarly, the smoking prevalence you can see in the slide in South Africa and also in Georgia also is really the significance, and it's quite high in TB population compared to the general population. There was another study that was carried out in Nepal to really they identify whether there was any relation between smoking and delay in health-seeking behavior. So the study revealed that smoking was found to be a major risk factor in delayed health-seeking and diagnosis and treatments of TB in Nepal. The median total delay was significantly longer, so almost 133 days per current smoker compared to 103 days for the former smoker and 80 days for never smokers. Among the presenting symptoms in TB patients, the cough and loss of appetite were significantly associated with smoking in Nepal. The observed association between smoking and delay in TB patients being established on treatments that suggest the smoker who experience TB symptoms may not present to the health services as early in the belief that their cough is due to smoking, and it may or may not require the treatments. So this suggests that the smoking would have marked the TB-related cough and may thereby contribute to a longer delay in assessing the healthcare and in assessing early diagnosis and treatments. So the same study also revealed that sputum smear positivity was also significantly associated with the smoking habit. It was found sputum smear positive. It was really the high, like a 3+ in 60% of the current smoker, compared to the in only 24%. You can see on the right hand side of the slide, the bar only 24% in never smoker and the ex-smoker. And it suggests that this is partly due to the smoking leading to a longer delay in TB diagnosis, as cough was attributed to smoking, as I mentioned earlier. As a consequence, we can say TB disease is at a more advanced stage. That's why they have more severity, and at the point of diagnosis, the smear positivity was also quite high, that is 3+. So therefore, if the person remain undiagnosed at the community with highly infectious, so there is a more chance to have the higher TB transmission at the community levels. So what are how to address this problem? So what we have done so far around the world, I would like to present some key findings. As I mentioned earlier, the Union and WHO has published a monograph in 2007, and from there in 2010, the Union has published a comprehensive guide to help the healthcare worker who works in the TB clinics to address the TB and tobacco the issues. And this guide presents a very simple steps, A, B, C. This is simple when the patient visits at the clinics. The DOTS clinic provider or a health clinic provider simply asks the question to the smoker whether they or the patient whether they do smoking or not, and the health worker can provide a brief advice quickly and also provide the cessation support. This is like a very simple approach, ABC, and it has been piloted in many countries around the world. And let me just highlight the quick the findings from the intervention. The brief advice was also implemented in many countries, as I mentioned earlier, particularly in Asia Pacific, in South Asia and East Asia. So here are the results from the Bangladesh and Pakistan that suggest that smoking cessation in TB population was found effective with better TB treatment outcome that you can see in this graph. Compare with the non-quitter, those who quit and better TB treatment rates, like 91 versus 80%. So you can see the quit rates among the quitter, the smoking quitter is substantially high, like I said, about 91%. But the people who didn't quit smoking, that's a non-quitter, is about only the 80%. So similarly, it also you can see the relapse rate. The relapse rate is quite high among the non-quitters. That is at 14%, but the relapse from the TB treatment is significantly low at 6% among the quitters. So regarding the sputum conversion, say at 9 weeks time, the conversion rate also is quite high among the quitters, but it's not that good at the non-quitters. So that means the smoking cessation intervention in the regular TB clinics really improve the TB treatments, the outcomes. So this is the study from Georgia. So it reveals that the success of TB treatment was found again quite high among never smokers and past smoker at 83%. So compared to the current smoker, only you can see the 67%, the success rate among the current smoker. And poor treatment outcomes were observed in current smoker as high as 25%. So this reflects the increase of the defaulter, the failure from the TB treatments, even death in current smokers compared to never and past smoker. So it suggests that if we do some intervention at TB clinics, like a smoking cessation, that would really contribute that will enhance the TB treatments and enhance the quality of life of the TB patients. So just the results of the smoking cessation in some clinics, in some countries in the Asia Pacific and also some other the parts of the world, we observed that in Bangladesh the quit rates was really the high at the point of 82%, and in India the smoking quit rates among the TB patients is 67%, and similar observation that we have also noticed in Indonesia and China as well. So these are the interventions carried out regularly in the TB services in our pilot in the areas. So that really shows something that smoking cessation intervention is feasible in the TB clinics, and it's doable through the existing healthcare systems. In Brazil, so it's not surprised. There is only the 15% quit rates at the month of 3, and because it was only there was only one time the brief advice at the point of the diagnosis. So, and after that there was no any follow-up. But in other countries there was regular follow-up throughout the TB treatments. So that's why you see the better outcomes compared to in Brazil. That's only one time smoking cessation. So it suggests again, so there should be a regular communications and interaction with the TB patient about the smoking and the tobacco control programs. So to conclude here, as I mentioned, there are now the millions of the evidence that suggests smoking is a significant risk factor for TB. We can increase likelihood of infection, death, relapse of the treatments, and greater clinical severity. And smoking cessation programs improve the adherence to TB treatments, and it also helps to reduce the defaulter failure and relapse from TB treatments. And also it also significantly contribute to reduce the mortality from TB. And as for the WHO, and it's we can the TB rates could be declined as much as 20% if smoking were eliminated. So that means if the smoking interventions are within the TB control programs, we can actually contribute the millions of to save the millions of lives. What are the next steps? So the first thing is, I think you all know and we all know, in TB control programs, early identifications, early TB treatments, and early prevention programs are really required, very essential. So as I mentioned earlier, so the smoking is really a significant determinants or significant drivers to fuel the TB, the epidemic. So it is very important to have better investments in tobacco control program within the framework of the TBs. So that would really help to contribute in ending TB as well. So what are the action that's needed? So the first, as I mentioned earlier, so we have several pilot programs in many countries that suggest smoking cessation must be an integral part of the TB education in regular TB services. In addition to brief advice, I think this is the time to really work with the donors and the country, the governments. So the NRT, that is nicotine replacement therapy, can be included in the comprehensive package care of the people with the TB. The second intervention that is really needed establish a system of active bi-directional screening for TB and tobacco, so that we can find more TB cases from the communities, and we can bring those cases, attributable to smoking as early as possible in TB treatments. So that early diagnosis and early treatments is really essential for TB control program. So tobacco control programs can contribute significantly. The second is again the investments and the integration. These are two key components here, keywords of tobacco control policy within the tobacco control action plan is critical. Because once the clinical side that smoking cessation can be done at the clinic, but at the population levels now, TB control programs really needs to work to with the governments for the policy collaboration, for policy advocacy and policy actions, and this action could be. The TB control program policy managers can join the tobacco control policymakers for implementing larger graphic health warning on tobacco packs to increase the awareness and promote the quit smoking, and the increasing tax and price on tobacco products that would really help to motivate the smoker to quit smoking and prevent the new start. And the money that we can generate from the tobacco tax or alcohol tax or any sugary the tax, that money can be used for the public health programs such as tobacco control, TB control, even the universal health care. So this is something the situation. The third is the ban smoking in all public places, as I mentioned earlier. The secondhand exposure is also another, the determinants for the TB disease. So the governments, both national and sub-national governments should work together to create environments where everyone can, breathe the clean air without tobacco smoke. So complete ban of tobacco advertising, promotion, and sponsorship to prevent and discourage smoking. So if we are really going to talk about the prevention of TB, we really need to also prevent our youth and children from the exposure of tobacco advertising, promotion, and sponsorship. So these are some the population level prevention measures as not only for tobacco control but also equally important for the TB control program as well. So I would like to stop here. Over to you, Shobha. Thank you.
Thank you, Dr. Baum, for a very, very lucid presentation. We have a question from Nahid Khalid, who wants to know that is chewing tobacco, which is more common in our South Asian countries, and are e-cigarettes also a risk factor for latent TB or active TB disease or drug-resistant TB? Chewing tobacco and e-cigarettes, other than smoking, are these also important for TB?
Yeah, definitely. These are also of course, the chewing tobacco is a big problem in our regions. There are some evidence, that suggests that this chewing tobacco also the problem, the TB disease as well. But we can see chewing tobacco is not only for TB but also for oral cancer, and there are many other, the health the consequences. And there are some the evidence also evolving now regarding the health harm due to the e-cigarettes. But still we need more information and more evidence to really show some concrete consequences of this. But the one thing is that we all need to work together to eliminate these the harmful products from the communities.
And there's a question from Bobby Ramakant that are the national tobacco control programs and national TB control programs working together enough in our region, in the Asia Pacific region, beyond cessation activities?
Yeah, that is also, I would say, it's not a challenge, but it's a big opportunity. It's a big gap there. So we don't have this, and there are some sort of collaboration between tobacco control programs and TB control programs at the national and also the subnational level as well. But there is no perfect, collaboration. So what we need now, a perfect collaboration. Both programs should work together. But unfortunately, in many countries, like a TB control program is a well-established program in many countries. It has a very good system, in terms of monitoring, evaluation, and providing the care. But in tobacco control, there is no such. In many countries, there is no well-established program. In some countries, it has been included within the framework of health promotion. In some countries, it's within the framework of NCD control program. It's a different, there. So I can see there are some good opportunities and it must work together. Both programs should work together to really address these issues. And these interventions, whatever I have presented here, is very, very cost effective. It doesn't require the huge money. What it requires is really a solid political commitments, as Dr. Elena mentioned earlier. It needs the political commitments, and those commitments needs to be translated into action. That is policy. If the governments come up with the policies, it can be well implemented.
Thank you very much. And now I have a quick question for each of our four speakers. And I want a brief answer also. Why is it important to engage local governments and leaders at the city level to deliver on the global goal of ending tuberculosis? And I think we can start in the reverse order. So I would request Dr. Baum to first address this question, and then we'll go on to Professor Mutallib, and then Arlena, and then Professor Guy Marks.
Yeah, thanks. The local governments, where is the problem? Actually, if you look at the problem in the community levels, and who knows the people at the community level, the local governments, who are in touch on a regular basis, that is local governments. So if the local problems are there, the problems at the local level, the solution also at the local level. And who are responsible to solve those their local problems is the local government. So it's a very simple, actually simple answer. So that's why that it's really important. Like Elena mentioned earlier, there are many good policies on paper at the national level, but at the national level, if they don't implement it on the ground, it's no use. So for the effective implementation of the policies on the ground, is a local governments play a big roles. And to identify the local problems and the local solution is only the local governments can do. So that therefore the engagements of the local governments is really, really critical. And we have some success in tobacco control, for example, in Indonesia. So even nothing's I would not say nothing, but it's very limited progress at the national level. But we have made really good progress at sub-national level, working with the mayors and the district heads, even the sub-district heads in terms of tobacco control. So it's local governments are the part of the solution, I would say. Yeah.
Yes, Professor Mutallib, what do you have to say?
Thank you again. I think what Dr. Tarasi mentioned, I think is very, very important. Like you already said, that if you take care of a family, the country also develops. The local government is just like a family here. So once a small family in local government actually gets the things done properly, then it reflects to the whole government in the country. Yeah? So I think that they are better sort of outcome for any disease for that matter. I think we should start from small to get the thing done in a bigger way. And that's the best thing for almost every disease in the country and in the world. Thank you very much, Shobha.
Thank you. Arlena?
Okay, thank you. As I always mention that we have a very good regulation, we have a very good SOP, we have a very good paper on document, but very weak, very weak in implementation. And regarding the problem in the community, I would say that local government should be put in loop. Otherwise, we fail because community is under local government. So that's why I said for TB, for instance, it does not only the business of medical doctor or medical staff, but everyone business. So let's have collaboration with all the stakeholder, then we can achieve the goal. So the problem is good implementation and put everyone in loop.
Thank you. Thank you very much. Professor Marks?
And I absolutely agree with Alina. I think that she's hit the nail on the head. I think the TB programs are responsible for treating patients with TB. But in order to find all of the patients with TB, as I was showing you before, you need to screen everyone. Okay, and TB programs can't do that. They can't do active case finding of the whole population. That's a responsibility for municipal, local government authorities. And so local government authorities, in the same way that they do other public health functions like maternal and child health, vaccination, there are many public health responsibilities that are not managed, in fact, by medical staff, but by local government authorities. And clean water, sanitation, all those things are really local government responsibilities in most systems. And so should case finding for tuberculosis be a local government responsibility. It's not something the national TB programs can actually manage. The national TB programs have to manage the cases that are found. Once you find a person with TB, they should be referred to the national TB program for treatment. But the screening for cases should be done by public health, by local government authorities. That's my view.
Agree.
Otherwise, we won't work. It won't be.
Fully agree.
Won't be feasible.
Thank you very much. And we will take one last question from Padamraj Joshi, who's a senior journalist from Nepal and editor of Health Today magazine. And Padamraj is taking the case of Nepal, but I think the same situation exists elsewhere too. He says that according to the Ministry of Health and Population, 69,000 TB patients are added in Nepal every year, but only 41% of them come for treatment. And the rest, that is 59%, are lost, even though TB treatment is free of cost. What needs to be done to reach out to these patients who are lost to treatment? And I think Dr. Burhan had also mentioned that there was 67% treatment coverage in Indonesia. So this is a problem with many countries. So what do the experts have to say to this? Any or all of? Yes, please.
I can start. I mean,
Yes.
I think that taking off, I think we need much better linkage between case finding, whether it's through the health system or through municipal screening, as I was just saying, and linkage into care. But I don't think it can be entirely left just to the health system and to patients' own devices. I think there needs to be some, I don't know whether this translates into English very well, but a carrot and a stick. You know what I mean when I say a carrot and a stick. So if you're diagnosed with TB, there has to be some responsibility that you have to take treatment, because if you don't take treatment, you will infect other people. Okay, so it's not just a matter for you. It's a matter of the rest of the community that you need to take treatment. So there needs to be some element of stick, if you like. There needs to be some responsibility. The carrot is that if you do take treatment, you are doing, in my view, a social good. You're doing a benefit for other people in your community by taking treatment. It's not that you're not taking treatment, as I say again, just for your own benefit. You're taking treatment, in fact, to prevent other people from being infected. And in exchange for that, you should be paid, in my view. And this is not a widespread view, but I think again to the system that existed in my own country back in the 1940s and 50s, when everybody with tuberculosis got a tuberculosis pension. Now, part of the value of a pension was it was meant to help people with financial difficulties, but it also provides an incentive and a recompense. It's saying, on behalf of the community, we are grateful that you are taking this treatment, and because you're doing us a social good, and we will pay you a small amount of money in exchange for you completing this treatment. So that's why I say a carrot and a stick. I think people should be paid for taking TB treatment, and I think they should be penalized if they don't, frankly, because they're putting other people in harm's way. So we need systems that are you need proper systems in place to implement this, and you need good linkage to care. But frankly, what's happening now is not working. And when only 41% of people who are diagnosed are getting on treatment, that is catastrophic, frankly. That's a disaster, because you've gone to all the trouble of making the diagnosis, but more than half of the patients still have the disease and can still spread it to other people. So we need to do much, much better than we have been.
Would anyone else like to say something on that?
Can I
Yes,
just
yes.
add that I agree with Guy saying that active case finding is very important. Yes, important, but we have to include local government, as mentioned also, and also not only local government, but community itself. Yeah, that's one thing. And yeah, giving carrot, I agree, but giving stick is also need to be done. Yeah, for instance, lesson learned from COVID. Again, I very am fine with
Not
COVID.
literally stick. I'm not.
Okay.
Not literally. I don't want to be taken too literally here.
Yeah, I know what you mean.
But you know, there needs to be some degree of compulsion.
Yeah, so this is what lesson learned from COVID. Yeah, if you have COVID in my country, in Indonesia, so your ID will be in our notification digital platform. The color will turn black. So that means you cannot go traveling, you cannot go enter the mall, you cannot go to your office. And I think if that the same thing being done to TB, but maybe not as dramatically like COVID, maybe we can do better. Yeah, people are aware that they need to be healthy, to be cured, to make others safe.
I would just, if I could just come back a little bit, there is a fine line to be drawn here. We want to avoid on the one hand, we want to avoid stigmatizing people with TB, but on the other hand, we do need people with TB to recognize that there is a responsibility, you know, that there is a social responsibility to take treatment. And we need a line that, you know, avoids people being stigmatized and excluded, but does encourage them to accept their responsibility to not infect other people.
Okay,
And
what
it's
is
the same sort of thing that we have with masks. I mean, you know, and COVID, you know, it's all very well to say you should be free to do what you want to do, but if your freedom means that other people are going to get infected with COVID, well, that's hardly justice. You know, that's not a just situation.
Guy, this is what awkward or funny thing about COVID that related to stigma. I don't think stigma is apply in COVID, because when you look up the social media, Facebook or Instagram, people will just say easily, "Oh, today I got COVID."
Yeah, now
In my house, there are 3 people got COVID, but that's never happened to TB. People
No.
doesn't want to tell that they're having TB. So we have to twist this situation that people will speak out. I have TB, but I will get the medication to get cured. Yeah. So I think
a very good point.
Yeah.
Yeah, very, very true. Yeah. And we got there with COVID. I think you're right. I think COVID has been destigmatized, and we need to do it with TB. Yeah.
Okay, thank you.
Thank you. Anybody else would like to add something, or?
I'm okay.
Yes. Okay.
And just one thing,
Yes.
you know, from COVID, what we have also learned is the accountability. You know, we can see both governments, whether it's the national or subnational, they are a bit accountable compared to the other programs. So I think this is something, a good momentum. We need to also hold the governments, and make them more accountable, actually.
Yes, and Professor Marks, I do agree there that I always have believed that my freedom ends where somebody else's begins. So that
Exactly.
it's important to draw that line. And I'm also reminded of what Dr. Soumya Swaminathan, the chief scientist at WHO, she had said recently that rather than missing patients, we have to see what is missing in our response. And only by involving affected communities and patient groups, as Erlina also mentioned just now, can we begin to solve the TB crisis.
Absolutely. Yeah, very true.
So with this, we come to the close of this conference. My sincere thanks to all the speakers for enriching today's session with their invaluable inputs. And of course, to our media friends and other members of the audience for their active participation. Special thanks to Asia Pacific Media Alliance for Health and Development for their hard work to make this conference a success. Stay safe, stay